Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments, but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475-bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air-conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theatres with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
Hi, good morning, and vanakkam to all the lovely viewers who have tuned in today. It's very rightly said that health is wealth, and I'm sure all of us agree with this saying. It's a bright Sunday morning, and it's amazing that we're discussing healthcare at this hour. And also to add, today, the 7th of April, is World Health Day. So, discussing this today makes it so much more meaningful. It is my pleasure and honor in welcoming each and every one of you to the webinar on understanding and managing thyroid disorders brought to you by Naruvi Hospitals under the Wellness series of the Hindu. Thyroid disorders have various perspectives, especially in Indian societies. However, most of the times we understand disorders the way they should be understood. So, today we have a panel of highly knowledgeable doctors who will be breaking down thyroid disorders for us. We're delighted to have with us Dr. Sheshadri, the Senior Consultant and Head of Department of Endocrinology at Naruvi Hospitals. A warm welcome to you, sir. We also have Dr. Sai Krishna Chaitanya, Consultant Endocrinologist at Naruvi Hospitals. A warm welcome to you as well, sir. And we also have Dr. Sai Krishna Chaitanya, along with our third speaker, Dr. Sriram Mahadevan, Professor and Head of Department of Endocrinology at Sri Ramachandra Institute of Higher Education and Research, Chennai. And my name is Iba Mariam, and I'll be moderating this wonderful session. This hour is all about wellness, so let's dive straight into it. After our speakers are done with their presentations, we'll be having an open question answer round so the audience can put up their questions in our live question box, and all your queries will be addressed by our speakers. Without holding up further, I would like to hand over the floor to Dr. Sai Krishna Chaitanya. So, doctor is someone who has a strong focus on listening to and addressing patient concerns. In addition, he's interested in answering all questions of patient in terms that they can understand easily. He has completed his MD and DM and has been a part of many research publications and paper presentations. He has been offering his insights on thyroid disorders, and I'm sure he has some good things to offer for us too. He is making his presentation on thyroid anatomy and physiology. So, welcome, doctor. The floor is all yours.
Thank you. Thank you, Hiba. Hope I'm audible.
Yes, you are, sir.
So first of all, I'd like to, I feel I'm very fortunate to share this webinar with the renowned speakers and renowned endocrinologists in India, Sashesh sir and Sriram Mahadevan sir. And also I would like to thank Hindu as well as Narvi Hospitals for giving me such a wonderful opportunity to speak on this topic of thyroid anatomy and physiology for the common public. That is more important here. So this is a very good session. And going into the topic, today my basic topic is thyroid anatomy and physiology. So where is it located? The thyroid gland is a butterfly-shaped gland which is located in front of the neck. You can see here, this is the prominence of which we call it as Adam's apple. Most of the thin individuals, we can feel that here. So the thyroid gland has a two lobes, which is this is called the right lobe and this is the left lobe. And you have a connecting it, you have a isthmus. So it is located in front of the neck, just below the Adam's apple. This is the location of the thyroid gland. How big is the thyroid gland? So what is the weight of the thyroid gland? So normally it weighs around 15 to 20 grams. What is the length of each lobe? Around 4 centimeters is the length of each lobe, and the width of each lobe being 2 to 2.5 centimeters. It is one of the biggest endocrine gland in the body. So when it starts functioning, the thyroid gland starts functioning as early as 11 to 12 weeks of gestation in the mother's womb itself. And birth, the child is completely independent and has its own functional thyroid gland. So the thyroid gland, when you look into the thyroid gland, how the thyroid gland is functioning. So what is the functional unit of the thyroid gland? So in the thyroid gland, when you cut it and look it under a microscope, you have many follicles. This is one such follicle which we are depicting in the picture. Like this, many follicles together form a lobule and together form a thyroid lobe. So these follicles contain two types of cells. One is a follicular cell and another one is a parafollicular cells. In the center, we have the colloid. So here the thyroid hormone synthesis occurs, and from here the thyroid hormones get synthesized and secreted into the blood. So what are the steps in the thyroid hormone synthesis? When you look at the steps in thyroid hormone synthesis, the first step will be the iodide trapping. The main element which is involved in thyroid hormone is iodide. Iodine. So the iodide trapping occurs, following which iodide gets converted into iodine in the gland, and after that the conjugation occurs and coupling, and then later the release of the thyroid hormones occurs. So the basic thing is the main element involved in thyroid hormone is iodide. That is one thing, and other element which is also involved is selenium. So these are the two micronutrients which are required in thyroid hormone synthesis. So how the thyroid gland is controlled? So we have, for every gland, the signaling should be coming from the top. So here in the brain, we have what is called as the hypothalamus. This hypothalamus produces a hormone called as thyrotropin releasing hormone. So this comes from the brain in the hypothalamus, and it acts on a very small gland which is located just behind your nose, in the just beneath the brain. You have a gland called as pituitary gland, which is called as a landmass of the endocrine system. It controls all the endocrine glands in the body. That the TRH comes and acts on the pituitary gland that produces thyroid stimulating hormone, and this thyroid stimulating hormone from the pituitary gland comes down via blood and reaches the thyroid gland, where it stimulates the thyroid gland in the neck to produce T3 and T4. When you look into a thyroid profile, we have T3, T4, and TSH. And T3 and T4 hormones are being produced by the thyroid gland, whereas the TSH in the thyroid profile is produced by the pituitary, which is located in the brain. So coming to the thyroid hormones, we have two types of hormones, T3 and T4, thyroid and thyroxine. So 90% of the hormone which is produced by thyroid gland is T4, which later on is converted into active form called as T3, which is peripherally converted into active form called as T3. And only 10% of T3 is directly produced by the thyroid gland. And they have a feedback relationship. So whenever the T4 and T3 are released, they go and suppress the TSH. So in that way, the smooth balance between T3, T4 and TSH is regulated. Whenever they are increasing, again TSH suppresses and the T3 and T4 are regulated in a normal way. So what are the components in the thyroid hormone? What are the components of thyroid hormones which we can normally see? So iodine, which is obtained from the diet, and thyroglobulin, tyrosine, residues of the thyroglobulin, which are synthesized in the body. So these are the basic components of a thyroid hormone. What are the effects of thyroid hormone? Coming to the effects, first we'll speak on the effects on metabolism. The carbohydrate metabolism, we have the increased glucose uptake by cells, which is mediated by thyroid hormones, and they also enhances glycolysis and glycogenesis. Glycolysis is the breakdown of the glucose, and glycogenesis is glycogen synthesis. And fat metabolism, it also, thyroid hormones mobilizes the fat, and they reduce cholesterol and also the triglycerides. And the protein metabolism, when you look at that, it also have both anabolic as well as the catabolic effects. That means it causes breakdown as well as synthesis of the proteins. Coming to the heart, for the proper normal cardiac pumping, thyroid hormones are required. And also to maintain a normal heart rate, thyroid hormones are required. So maintenance of normal cardiac pumping and normal heart rate requires presence of thyroid hormones. Coming to the female reproductive system, which we are facing nowadays many of the problems. So it is required for normal ovulation in case of female. It requires for normal follicular development. And also it is required for proper maintenance of the endometrium for implantation as well as the development of the embryo. Coming to the male reproductive system, it regulates the ejaculatory processes. It also maintains the spermatogenesis and maintains the quality of semen. Other functions being maintenance of the skeletal growth along with other hormones, and it also helps to maintain normal gut motility. Any alteration in thyroid hormones are going to alter the gut movement of the your bowel loops, so thereby causing constipation or hyperdefecation. Thank you. Thank you for the wonderful opportunity.
Thank you very much, Dora. That was indeed some ice breaking that was very much needed. So thank you so much for sharing your thoughts on that. Next up, we will dive into the topic of hypothyroidism. So to share his valuable insights on this topic, we have with us Dr. Sheshadri, Senior Consultant and Head of Department of Endocrinology at Naruvi Hospitals. So he retired on August 2nd, 2011 after 34 years of dedicated service at CMC Vellore. He's not just a brilliant clinician, but also a prolific researcher and an exceptional teacher. He is a doctoral guide for both clinicians and laboratory specialists and was instrumental in initiating the DNB course in endocrinology in 2001. He's been a reviewer for several medical journals and a much sought after speaker for conferences and seminars. Doctor was also a member of the task force for stem cell research and regenerative medicine of Department of Biotechnology, Government of India, and a member of the Human Resource Development Group, CSIR. It's wonderful to have a dignified personality with us. So welcome, Doctor. The floor is all yours.
Thank you very much, Iba. Thanks for that very nice introduction. Can I share my screen now?
Yes,
Or
sir, you can.
okay, it is very nice to be here in this forum on the World Health Day,
Yeah.
trying to educate public on a very common but confusing disorder. This is actually thyroid disorders.
Correct, correct.
My task today is going to be to talk to you on hypothyroidism. Is my screen visible? Hello?
It's blank. I think it's the end of the show, sir. You have to go to the first slide.
Okay. I'm not able to see it here in my screen. Let me.
Yeah, maybe you can try
Okay, okay, right,
initially.
okay. Can I share again?
Yes, sir, please go ahead.
Okay. You may wonder why I have these black and white slides, because I think it's a good idea to have things black and white as far as possible in this particular area. Okay. Now, thank you very much to Sai for having made my task much easier by talking to you in very simple terms about thyroid physiology. I'm going to talk about hypothyroidism, which basically is low circulating levels of thyroid hormones, T4 and T3. Commonly, this is because of the failure of the thyroid gland. So it's called primary hypothyroidism. There is decreased secretion of T3, T4 from thyroid. And as Sai explained, because of this, there is an increased production of TSH from the pituitary in a futile attempt to stimulate the thyroid gland. In the initial stages of hypothyroidism, actually T3 and T4 are normal, but TSH is mildly elevated. The mildly elevated TSH ensures that the thyroid gland still produces enough hormone. We call this subclinical hypothyroidism. But in the later stages, when the production of thyroid hormones is markedly decreased, the TSH becomes markedly elevated, patients become symptomatic. We call it overt hypothyroidism. The most common cause for primary hypothyroidism is what we call autoimmune thyroiditis. It's an autoimmune destruction of the thyroid gland over a period of several months or sometimes years. This is actually, there is a marker for autoimmunity of the thyroid gland, an antibody that circulates in blood, which is called thyroid peroxidase antibody. Less common causes for thyroid hormone deficiency are after removal of the thyroid gland surgically or after ablation of the thyroid gland with radioactive iodine. Radiation to the head and neck region for cancers in that region can also lead to hypothyroidism. And of course, if the pituitary is hypofunctioning, the stimulus for the thyroid is gone, and so you can have thyroid hormone deficiency. You must remember that some drugs used in treatment can also alter thyroid function. Lithium used in psychiatric practice can cause hypothyroidism, as also amiodarone, a drug used for controlling heart rhythm. As I mentioned, thyroid hormone acts virtually on all tissues and organs of the body, and therefore the symptoms pertain to all organ systems. The word to remember is actually slowing. The basal metabolic rate is slow. They cannot tolerate cold weather. The skin becomes dry, cold, sweating is reduced. Heart rate is low. Production of blood cells is decreased, so hemoglobin is low. The respiratory rate is decreased. And when you sleep, the upper airways may be blocked because of edema of those tissues during sleep. The gastrointestinal tract is affected in terms of poor appetite because of sluggish stomach motility, but still patients gain a little bit of weight, say 4 to 6 kg. Bowels do not move properly, and so you have constipation. Renal function is altered, and the glomerular filtration rate is decreased. Serum sodium tends to be low. The fluid retention, so patients develop edema, puffiness of the face, fluid collection inside the pleural space and in the membrane surrounding the heart, pericardium. The disposal of drugs becomes slow, so patients with hypothyroidism are at risk for toxicity to drugs at normal doses. In the reproductive system, women menstrual periods are altered. There's maybe cessation of menses for several months. There can be irregular bleeding. There can be milky secretion from the breast. Can be a disorder of ovulation, infertility, and there can be problems during pregnancy, preterm labor, pregnancy loss, and in men, it can be loss of libido and altered sexual function. The nervous system can be affected in terms of difficulties with thinking, reasoning. These may be altered, can be mood swings, movements can become slow, the speech becomes slow and slurred, voice becomes hoarse, hearing may be impaired, balance may be impaired. But remember, the symptoms I have listed are very impressive, but all symptoms do not occur in everyone with hypothyroidism. Permutations and combinations occur, which is why it is a great mimic. The patient may land up with any specialist, and if the index of suspicion is low and appropriate tests are not done, diagnosis is delayed or sometimes missed. Now, one popular misconception that I want to dispel: obesity. Now, this person is actually obese, the generalized marked increase in weight. Please remember, weight gain due to hypothyroidism is very modest, only 4 to 8 kgs at the most. So, a lot of obese patients are under the mistaken impression that they have hypothyroidism, and very often they are on doses of thyroxine that are inappropriate. Hypothyroidism can occur during any phase in life. In the newborn, if it is unrecognized, it leads to abnormal brain function. So, a child doesn't develop normally. So, it is very important to screen all newborn babies with thyroid function tests. It's called universal screening. In children, growth is compromised. Children land up having short stature. In later childhood, there can be abnormalities of sexual maturation or puberty. The pubertal process can be either delayed or rarely it can occur too early. In young women, there can be menstrual problems, ovulatory problems, which bring them to the hospital. Now, I'll illustrate this with a few patients. Look at this child, newborn child. If you look at it, it looks like a child who is sleeping, right? Looks quite normal. In fact, the child has quite gross hypothyroidism. T4 is quite low and the TSH is markedly elevated. Now, this is the stage at which a newborn should be diagnosed with hypothyroidism. If you miss the diagnosis at this stage, this is what happens. The child has abnormal development. You can notice that the child is looking very dull, has got a hernia, the umbilical region. And if you allow the diagnosis to be delayed to the stage, then the child can have abnormalities of higher intellectual functions. Now look at this girl. At the age of 7 years, she was only 96 centimeters tall, and she was found to have hypothyroidism. She was treated with thyroxine, and over the next 4 years, she grew to 119 centimeters, about 24 centimeters weight gain, and this is very impressive. So remember, short-statured children, you should think about hypothyroidism and probably test. Now look at this child. This child, who is only 7 years old, already shows some signs of puberty. There is some breast enlargement. Now, this can occur with primary hypothyroidism, but when this occurs in the setting of actually compromised linear growth. She is only about 96 centimeters tall. All right. So, short stature with precocious breast development, you should think of hypothyroidism. Now, this is a lady who was referred to me. She had some milky secretion from the breast, and she had been having loss of menstrual periods for about 6 months. And so the attending gynecologist actually did a prolactin level that was very high. So she suspected a pituitary tumor and went straight for imaging of the pituitary gland. And this is a pituitary gland which is actually quite enlarged, and it is going and touching the optic chiasma, right? So this was referred to me as a patient with a pituitary tumor. Actually, this is not a pituitary tumor. This lady had hypothyroidism, okay? thyroid hormone levels were way down. Free T4 was very low. TSH was markedly elevated. The thyroid antibodies were present in high concentration. And this was primary hypothyroidism. Then why did the pituitary gland enlarge? It enlarged because the cells that produce TSH in the pituitary, they increase in number and size. And so it gives the appearance of a pituitary tumor. We call it a pituitary pseudotumor. The thyroid function tests in pregnancy, I think people need to know about that. Many countries recommend only selective screening. People who have had prior thyroid surgery, radioactive iodine treatment, presence of a thyroid swelling, previous thyroid autoimmunity, or a family history of autoimmune thyroid disease. These are the indications for thyroid testing in other countries. The Indian Thyroid Society, on the other hand, actually recommends universal screening of all pregnant women. So because subclinical hypothyroidism in pregnancy, treatment is required. And during pregnancy, free T4 and TSH are usually monitored once in 2 months and dose adjusted to maintain normal TSH. So this is something that is recommended by the Indian Thyroid Society in the interest of patients. The objective is to ensure optimal pregnancy outcome. Now, people always think of thyroid disease as something, hypothyroidism as something where you require lifelong treatment. That is very true in most of the patients. But sometimes hypothyroidism can be temporary or transient. This means you need thyroxine only for some time and then it can be discontinued. This occurs in a condition called thyroiditis, can be acute or subacute, and sometimes after delivery, hypothyroidism is temporary or transient. Now, your doctor, if he suspects this, may ask you to discontinue treatment after a few months, and they may follow up your thyroid functions. And if it is transient hypothyroidism, you may remain free of thyroid hormone treatment for many years after the initial diagnosis. Now, we all think of hypothyroidism as a disorder that may not threaten life. That is untrue. Hypothyroidism can be life-threatening in certain situations. Now, unrecognized hypothyroidism is what causes problems, particularly when the patient has an acute illness or when the patient is going for surgery. Somebody who has not been diagnosed with hypothyroidism, diagnosis missed, the patient has come with an acute illness, or the patient has to go for major surgery. Now, that kind of situation, patient can become unconscious. We call it myxedema coma. They have very low body temperature, hypothermia. They can have respiratory failure, and this condition has a high mortality. And because of this reason, people need to be aware that thyroid functions probably should be checked before major surgery. And if any acute illness is not responding in the usual way to treatment, you need to think about coexistent thyroid deficiency. The cornerstones of management of thyroid deficiency is high index of clinical suspicion, early diagnosis. I am happy to say this is done more frequently now. When I was a medical student, hypothyroidism often used to be diagnosed very late. Treatment, of course, is very simple. You just replace the missing hormone. The hormone is actually absorbed through the mouth. So oral intake of the prescribed dose of thyroxine, usually lifelong, is the treatment. The problem is the patients do not really comply with instructions. They want to try alternative forms of treatment. They want to try yoga. They stop the medication and they develop symptoms and then keep coming back to it. Patients want a cure for hypothyroidism, but we keep telling them we can only control it and we can only prescribe medications to be taken on a regular basis. Unfortunately, the only treatment for hypothyroidism is thyroxine. There is no other treatment. A lot of patients come to us with suboptimal control of their hypothyroidism. They come and say, my TSH is always out of control. Usually, in these situations, thyroid hormone levels, T4 and T3 are nearly normal, but TSH shows mild to moderate increase. The reason in virtually all these patients is actually missing out doses. Anyone on lifelong medication can be, you can imagine, we'll miss 1 or 2 doses in a month, okay? If you are given a 5-day course of antibiotics, how many of you take it regularly? Not really, right? So this happens with lifelong medication. There are some simple tips I have for patients. Take the dose first thing in the morning, keep it on the bathroom shelf, take it as soon as you brush your teeth. If you miss the morning dose, take it later when you remember. If you miss for a whole day, take the extra dose next day morning. You can do this with thyroxine because it's a long-acting drug. Use a pill organizer, fill it up every Sunday, and if you look at it, you know whether you missed a dose or not. Keep a supply of your tablets in your travel bag. Okay, that's another reason why people miss out tablets. Now, the follow-up, once a stable dose of thyroxine is reached, we usually see them once in 6 to 12 months. This is mainly to ensure compliance. We check and then we find out patients are taking it regularly, and actually make this follow-up is important to enhance compliance. Thank you very much for a patient listening.
Thank you very much, Doctor, for sharing your insights. I'm sure people will have a lot to learn from your presentation. So, thank you so much for that. Let's now move on to our third speaker for the day. So, our third speaker for the day will be Dr. Sriram Mahadevan. So, Doctor has completed his MBBS at Stanley Medical College, Chennai, and his MD and DM from the Postgraduate Institute of Medical Education and Research, Chandigarh. Currently, he is serving as a professor and head department of endocrinology, diabetes, and metabolism at Sri Ramachandra Institute of Higher Education and Research, Chennai. He has published more than 120 articles in peer-reviewed index journals, 19 chapters in textbooks of endocrinology, medicine, and diabetes. He's been awarded the Honorary National Professor by Indian Medical Association, College of General Practitioners in 2015. He's also been awarded the Inspiring Endocrinologist by Economic Times Group in June 2023. He was formerly the Vice President and Finance Secretary of the Endocrine Society of Tamil Nadu and Puducherry, and Executive Committee member of ISPMR. He has a special interest includes thyroid, metabolic bone, and gonadal disorders and diabetes. It's lovely to have such a resourceful person in our midst today. He'll be sharing his thoughts on hyperthyroidism. So, welcome, doctor. The floor is all yours. So, you're on mute.
Thank you very much. And once again, thank you very much for the opportunity, and a very good morning to everybody. My audio is okay. I'll share my screen for the next 10 minutes on. I will brief the audience who are listening today on thyrotoxicosis, which is the other end of the spectrum of what Dr. Seshadri sir spoke on. That was the underactive thyroid gland. This is either overactive thyroid gland or blood levels of thyroid hormones being high. So these 4-5 small questions we will answer over the next 7-8 minutes and throw open for further discussion. The very simply put, thyrotoxicosis is a medical term where we mean that the blood levels of the thyroid hormones are high. Why high? In the next few minutes, the audience will be able to clearly understand how we approach this problem. Before going further, it is very easy to understand that in Dr. Sheshadri sir's talk, in underactive thyroid gland or hypothyroidism, a patient is taking thyroxine tablet. Inadvertently or due to various other medical reasons, if the dose of that thyroxine is high in that patient, that will also be called thyrotoxicosis, where the blood levels of thyroid hormone will be high. That is what we mean by this. But there are conditions where the thyroid gland, without any supervision, or any feedback control, starts producing more thyroid hormone than required autonomously. Those conditions will be our main focus. So, in contrast to what happens in hypothyroidism, thyroid hormone acts like a catalyst in optimizing the speed at which all the biochemical reactions at the cellular level are taking place in our body. So, when thyroid hormone or hormone is excessively secreted, it is generally conceptualized, which is fairly correct, that the metabolic rate will go high. You can imagine everything going fast. For example, heart rate will be high, the nervous system will be more jittery, more alert, but not focused. So there will be tremors, excessive sweating, excessive bowel movements. So all when it will be like somebody running a marathon kind of a feel the patient will be having. So tired, weakness, and weight loss is a very important symptom. In contrast to hypothyroidism, where, as Dr. Seshadri sir very clearly pointed out, that in spite of weight being associated with hypothyroidism, but it is a very meager 3 to 5%. In thyrotoxicosis, especially when the gland is overproducing, you will be the audience may be surprised that the weight loss can be very significant. Sometimes to the extent that the treating physician may be wondering, are we dealing with any other malignancy or any other serious infection, when it will turn out to be a simple thyroid problem. So these are all the common symptoms I have put here. The beauty of the presentation is such that sometimes the patients can go to any specialty. Like, for example, a patient who is anxious, over anxious because of hyperthyroidism, too much of tremors, and not focusing, etc., can go to even a psychiatrist for anxiety related symptoms. These are, to put in a very simple word, the primary physician who deals with the patient should have the index of suspecting this condition very early. Otherwise, as Sir was pointing out, hyperthyroidism or thyrotoxicosis can also be missed for several weeks or months before the patient is diagnosed. So, as I said, in ladies especially around the menopause period, they will have symptoms which are due to menopause, which can be a mimicker for actually hyperthyroidism. And there are umpteen number of other conditions in today's lifestyle where the patient will be over anxious for multiple other psychological reasons, for which they may get their thyroid repeatedly and at every time being normal. So this is just to tell you how both sides of the story as a physician we have to manage. There are symptoms which can be common between hypo and hyperthyroidism. For example, this tiredness, fatigue, hair loss. Every lady in our community, in our culture, they tell about hair loss as a very prominent symptom. Menstrual irregularity. Even though classically in medical college teaching, we say that hypothyroidism causes excessive bleeding or menorrhagia, and hyperthyroidism may be associated with very low bleeding or hypomenorrhea. That may not be the situation always. And anemia. These are all symptoms which can overlap. But I would also like to mention that in people who are elderly, especially 70, 75 plus, there this hyperthyroidism will be so masked that they may not come with these classic symptoms which are mentioned here. They may be in depression. They may in fact have appetite loss rather than high appetite, and that will be called apathetic thyrotoxicosis. This again, the awareness about these atypical presentations and the suspicion should be from the physician's purview. Thankfully, today the tests are simply and easily accessible, very easily done. So, with a simple blood test, we can diagnose these conditions very easily. So, the causes can be broadly classified as: number one, the audience should probably listen to this slightly carefully. The gland is acting like a factory where it produces the thyroid hormones from the raw material of iodine and protein, which forms tyrosine, which is the amino acid. So, if the chemical factory, a good chemical factory like thyroid gland, is affected by an infection, most commonly viral infection, very common, and the gland, the factory itself gets damaged, so the stored hormones or the chemical in the factory gets released into the bloodstream. That will exactly mimic the same situation as to when the gland is producing more hormone. So the first step in our approach to a patient who comes with thyrotoxicosis, which is high thyroid hormone level, is to see whether gland is damaged and release of all the hormones present in the gland is coming out, or the gland is overproducing. This is important because the treatment will slightly vary. In fact, in the first case, as I have mentioned here, which is the inflammatory damage to the gland, or it could be due to viral infection or sometimes due to drugs, is most often self-limiting, and nature itself will cure many times. Almost 2/3 to almost 80% of the time, the gland will recover, the factory will start producing again. So in the left half of this inflammatory damage, subacute thyroiditis kind of a picture, we usually don't treat at all. We give only symptomatic treatment with what we call beta blockers to reduce the palpitation and high pulse rate, and we will give maybe paracetamol or some fever related medicine, pain related medicine, etc. This could be differentiated by simple tests, which I will come to in the next couple of minutes. In contrast, the overproduction of thyroid, the most common is autoimmune, where the immune system of our body acts against our own organ. In this case, it is thyroid, producing thyroid more. That's called Graves' disease. There is nothing grave about it. This is a very simple treatable condition. It is one of the scientists' name. That is why the apostrophe follows the S here. So that is one condition where the gland is diffusely involved and produces more, or there could be sometimes nodules, which are focal area of the thyroid gland, which starts producing hormones autonomously in excess. So the physician whom you approach, a thyroid trained doctor, will be able to differentiate these two with simple blood tests and couple of scans. What tests we do to confirm these thyrotoxicosis? Because even though you can suspect clinically, just now I mentioned that anxiety, menopause, and early pregnancy, there could be many conditions due to which the symptoms will mimic the same. Interestingly, we don't diagnose thyroid excess or, for that matter, even hypothyroidism by actually T3, T4 levels, which are the hormones produced by the gland. We diagnose dysfunction in thyroid gland synthesis or production by TSH, which is the thyroid stimulating hormone from the pituitary. Dr. Chaitanya nicely brought out this point that there is a feedback mechanism we call in our medical parlance. So, if the TSH is very low, it means the thyroid gland is overproducing. If the TSH is very high or high, it means this gland. So, we diagnose thyroid problems by the TSH. So, any suppressed TSH, there should be a suspicion of excess thyroid hormone. That is how we diagnose. This is the first basic test. So, as mentioned here. In addition, we may have to do antibodies to sometimes confirm whether this has an autoimmune tendency. By the word autoimmune, we mean that genetically some people are prone to produce certain antibodies which act against certain tissues in the body. It doesn't mean that these antibodies are causing the problem, but these antibodies are giving us a marker or an indication that there is an underlying immune related problem which is causing this condition. And in case of hyperthyroidism, we may do another antibody called TSH receptor antibody. This is slightly costly. If available, it helps in difficult cases for us. Then comes scans. Mainly, we do nuclear scan. If available, this is sometimes very useful because the first question every patient will ask after a thyroid problem is diagnosed. As sir was saying in the previous talk that it is lifelong problem. Will I come out of this problem? As I just mentioned, if the patient has a simple inflammation related thyroid problem, very often they may recover. So for that, if you do that nuclear scan called technetium thyroid scan or radioiodine uptake scan, especially technetium is easily available in many places, especially in cities. If it done within, and it should be done when the patient is having symptom, not after 2 months of recovery, because in 2-3 months the condition itself will recover. So in which case, it will all a clinical decision taken by the primary doctor who sees this patient. And if the inflammatory damage, the uptake will be very less, and overproducing gland, it will take up the technetium excess. So with that, we will easily confirm. It will be very easy to tell the patient whether you are going to have a treatment for a longer period of time or whether you are going to recover. So it gives a lot of confidence in confirming and monitoring the patient. That's why some of the scans are done in many of the patients where we deal with thyrotoxicosis. Ultrasonography is done only when there is nodularity suspected. Every time checking an ultrasonography for a routine thyrotoxicosis may not be required unless clinically you feel that there is an asymmetric enlargement of the gland, or one side you feel some consistency which is different. I need to stress here that CT scan and MRI are very rarely required to diagnose or confirm these conditions, extremely rare. So it will not be appropriate to do these scans at the initial go in these patients. So as the treatment part is oversimplified here, it has to be individualized, but I would like to clearly mention that the treating physician has to go through this algorithmic approach which we just now mentioned. If it is a straightforward case of inflammatory damage due to a recent infection, then it is only self-limiting. Most often during the flu illnesses, we get these cases during the August, September rainy season. Very often this will be thyroiditis. So there we have to reassure the patient and follow up. In contrast, hyperthyroidism due to Graves' disease or autoimmune hyperthyroidism is the most common cause of overproduction of thyroid, and there either we usually go by medical treatment, or in a given case based on multiple other indications, I wouldn't want to confuse the lay audience today. We may have to opt for either radioiodine ablative therapy or surgery, depending on the size of the gland, nodularity, follow up, age, comorbidities like whether they have heart problem or they may plan pregnancy in the future, etc., etc. There are multiple other issues. So very often, the selection of therapy for thyroid in a given patient is not based on the thyroid level or not based on whether the goiter, the swelling is there, etc. These are also important. More importantly, age of the patient, pregnancy plans, comorbidities, any surgery planned in the near future. Those also will be taken into consideration while selecting the therapy for a patient. And there are some very common myths, just a couple of them to mention. Hyperthyroidism, by whatever I was stressing now, it is rarely lifelong. We need not, immediately jump to say thyroid means lifelong, I will not be able to stop, etc. Even the hyperthyroid Graves' disease, usually within 1.5 to 2 years of proper regular therapy, I double underline that word, you will be able to, the autoimmunity will go into remission, the gland will go into overactivity, will go into a sleep mode, and the patient will become better. And this regarding this iodine and salt, etc. In general, iodized salt is indicated in all patients with thyroid problem. Let us not go into these controversies of too much of the Googling and WhatsApp University based data. Except rare situations which your physicians will be able to tell you, we advise only routine normal iodized salt in our practice. Cabbage, cauliflower, this recently millet, all these are confused again and again. All these can be taken in normal amounts in a given patient with any of the thyroid problem which we are discussing today. And the common myths like, immediately making it a social stigma. Once a lady is diagnosed with thyroid problem, it will affect her fertility, it will affect her pregnancy, etc. All these, I have to add a rider here saying that unless it is not treated well, unless you keep it so uncontrolled, these are not going to get affected. And so, with these few points, again, I would like to stop my talk today. Thyroid toxicosis, which is excess thyroid hormone in the blood, which could be as simple as an over treatment of hypothyroidism or other conditions which I just mentioned, has to be suspected whenever there is unexplained weight loss, palpitations, sweating, etc. Go through the symptomatology in an objective way. Simple blood tests will confirm thyrotoxicosis more often. Today we have very good lab facility, third generation, highly reliable facilities are available in smaller towns also. And further testing will be decided by your endocrine physician or your senior general physician who will be looking at you. Treatment is simple, as was mentioned by Dr. Seshadri sir also. Here also the treatment is not very complex, but follow-up should be very regular. Monitoring periodically is absolutely mandatory. Thank you very much on this important occasion of World Health Day for this opportunity to talk on an important common topic, public health problem. Thank you.
Thank you very much, doctor, for sharing your thoughts. And I think we should take this moment to thank all the three doctors who have given us like so knowledgeable thoughts on this topic, because many of them you had explained them in like simple words to make everyone understand. So thank you so much for that. And also, like I had mentioned, we had an open question answer forum. So we've had like 14, 15 questions, I think. So I will be posing the questions. Whoever wishes to answer can unmute and take up the questions. So our first question came up like in the beginning of the webinar itself. So we have someone who says, my age is 41. I'm taking Thyronorm 75 mg, TSH value 3.3, T3 2.65, T4 1.46, and ATPO is 889.6. My question is, why is the ATPO 889.6 against the 60.0 value? I'm not sure if you remember the values, but if anyone wishes to answer, you can please go ahead.
Take it on. This TPO antibody is a marker of thyroid autoimmunity. Okay, it is not a test that tells you how the thyroid gland is functioning. It tells you something about the cause for the thyroid hormone deficiency. It is done only once, right at the beginning, when you want to find out whether autoimmune thyroid disease is causing hypothyroidism or not. There is no merit in repeating it every time the patient comes. So you should not do it at follow-up visit, because it confuses people. They see a value, normal range up to 60, my value is 600. So it just gives them an unnecessary headache and causes anxiety. So do not repeat TPO values after the first time it is done. Not required. Going by a thyroid function test, you are in the perfect control. Just continue the same dose of thyroxine. Okay.
Thank you very much, sir. We hope that answered the question. We'll move on to our next question. So this question says, what is the relation between diabetes mellitus and hyperthyroidism? Whoever would like to answer can take over the question.
Hypothyroidism. Okay.
Hyperthyroidism.
Hyper. Okay. Dr. Sriram.
Sir, in general, excess thyroid hormones increase glucose. This is general understanding. Exceptions I don't want to go into. So, controlling and keeping your thyroid as normal as possible helps in your diabetes control also. It applies to both hypo and hyperthyroidism. The question was more specifically on hyperthyroidism, which is a direct, if I put it that way, it will add fuel to the fire of increasing glucose. So, in fact, to the extent that if you are going for confirming diabetes diagnosis, you should first, if you are hyperthyroid, you should control your thyroid first and then repeat. So, generally, this is the relation, and the control has to be as good as possible for better glycemic control. There are type 1 diabetes. I don't want to go and confuse more here. This is what I answered till now is very, very commonly faced type 2 diabetes problem. In type 1 diabetes, that is autoimmune directly, and this condition also being autoimmune, many of the patients have both the problems together. So proactively, we have to screen our type 1 diabetes young patients every other year for thyroid problems. So they are an unholy nexus in general. We have to screen them.
Thank you very much, Dr. Sriram. I'm sure that answered the question. We'll move on to our next question. It says, sometimes we see more of T3 than T4. What does that mean?
The laboratory test for thyroid function, the most important test is actually T4. Okay. T4, and more important than that is the TSH. Okay. Now, the reason we say T3 is not a very important test is because, number one, the margin of error with T3 measurements is actually higher. The laboratory margin for error measuring T3 is higher. Number three, all patients who have thyroid function abnormality, you may find the T4 and TSH give you an answer. There are very, very select situations where T3 is actually required. There are some patients who have what is called only T3 toxicosis. These people, TSH is suppressed. You do a T4, T4 is actually normal or even a little low, but you do a T3 that is high. But that is exceedingly rare. Okay. So the T3 test should be done by the discretion of the physician when required and not routine. When you do a test routinely, and you get a T3 value that is a little above normal, T4 is normal, TSH is in the normal range, you are not going to change your management. Okay. So in general, I think T4 and TSH are sufficient, and the two, we now have measurement of free T4 available, which is a pretty useful measurement. T3 only in select situations. And again, I would counsel you not to keep doing it repeatedly. Okay. Don't do it repeatedly because you'll get confused with the value. Say, my T3 is high, should I reduce my dose of medication? No, you don't do that. Okay.
Thank you very much, sir. I think that was a lovely answer that did complete justice to the question. Thank you so much for that. We'll move on to our next question. So our next question goes, what are the indication of radioactive iodine uptake studied in management of hyperthyroidism? Does all the hyperthyroid patients need RAIU, as many of the corporate hospitals do that routine for all hyperthyroid patients?
Shall I answer, sir?
Yes, go ahead. Please go ahead. Yeah.
I,
Yeah,
I, I think I mentioned during my talk, it may be highly relevant to do this scan, especially the technetium scan is a very, very cost effective scan in most of the setups. Because the questions which are answered by these are very, very convincing to tell the patient how long the treatment will continue, confirm the diagnosis, whether it is due to nodule or not, whether it is only if the clinical telltale signs of diffuse toxic goiter, which is Graves' disease, are there. We call it infiltrative ophthalmopathy or infiltrative dermopathy. See, if the more the experience, the more the senior physicians see with all these other clinical features, maybe in a given patient, I may take a decision not to do the scan. Or if the patient does not know her last menstrual period, we are not sure of this, there, I cannot do these nuclear studies in the patient. And there was a time till recently we didn't have the other specific antibodies like TSH receptor antibody, which are reasonably confirmatory kind of tests in these conditions. So with the non-availability of some of the specific blood tests, and in a given clinical situation, I'm confused as to whether I'm dealing with the the inflammatory condition or a long-term condition. Scans are very, very useful. It is not done for just commercial reasons alone. I think the person who is asking should understand this. It gives a lot of confidence in both the patient and the treating team as to what we are doing. So, and we look for all reasons not to do the scan also before we do it. So, once done at the right time, and if it is a clear cut inflammatory condition, it is extremely gratifying to tell the patient, no, nothing to worry. Within few weeks, you will be all right. Imagine the same situation the other way, where I had to tell, this will be a long term problem. You need to take tablets for a longish period and regular follow up. So that way, it is very useful. That's what is my answer.
Thank you very much, Dr. Sriram. Thank you so much for answering that. We'll move on to our next question. So our question goes, how often during pregnancy do we need to take a thyroid test? Dr.
No,
Chaitanya, would you want to take it up? Okay, yeah, you can go ahead, Dr.
no,
Seshadri,
fine.
please.
Chaitanya,
How often we want to take in pregnancy is till we achieve the euthyroid status, we always monitor thyroid function at 4-week intervals. So once we achieve the euthyroid state, then we can reduce the frequency of monitoring. So this is how we follow the thyroid. First ANC, it's always routine to do a thyroid function test, and we need to check the thyroid hormone levels and the TSH levels anywhere between more than 4. We try to treat that, and between 2.5 to 4. We take other things into consideration, whether the antibody positivity or negativity. Based on that, we try to treat the patients. When antibody is positive in those patients also, we try to treat them. After 4 weeks, we follow up them with the thyroid profile and then adjust the dose accordingly. We don't want even the slightest abnormality also in the thyroid function in pregnant individuals, as the baby is also dependent on mother for thyroid hormone requirements.
Thank you
just
so much, Doctor.
if I
Yes,
may
sir, please add.
clarify one point. In the Indian Thyroid Society, says all pregnant women should be screened for thyroid function. Okay, then you have people who have abnormal thyroid function and those who have normal thyroid function. Those who were screened and found to have a normal thyroid function, you don't have to do it every month or every 2 months. No. If the patient was diagnosed to have hypothyroidism and treatment was given, then you monitor them once a month initially, once in 2 months later, to make sure that the problem is under good control. So the majority of women who undergo this screening will have a normal thyroid function in the beginning, and you don't do anything about it. You just leave them alone.
Right. Thank you very much, Dr. Sheshadri and Dr. Chaitanya, for answering that question. We hope it answered the question of the person who asked it. So our next question goes, what is the food to be avoided in hypothyroidism? Who would like to answer the question?
I'll take that.
Please. Sure, sir.
No, eat a healthy diet. We are not going to say you don't eat this, you don't eat that. Eat a healthy diet. Cut down on carbs if you are overweight. Take enough protein. Take a lot of vegetables. No vegetable is taboo. Dr. Sira very clearly mentioned that. All vegetables you can take. You can take millets. Okay. So we don't prescribe any food item in patients with hypothyroidism. A lot of misconception in the minds of people about this because they Google. Okay. So I think, let me tell you very clearly, all food items are allowed, but have a sensible and balanced diet.
Right. A balanced diet just makes everything balanced, and your answer made complete sense of it. So thank you so much, sir. We'll move on to our next question. So our question goes, is there any relation between the thyroid deficiency and anemia?
Yeah, of
Whoever
course.
would like to answer. Yeah,
Yeah,
please.
of course. I mentioned that you do get anemia and thyroid hormone deficiency. It can be due to many factors. I said everything goes slow, so your bone marrow also goes slow and produces fewer RBCs, right? Then Women with thyroid problems tend to sometimes have excessive menstrual bleeding, so they have blood loss. So they have an element of iron deficiency added on. And we mentioned the thyroid disease most often is autoimmune. As part of an autoimmune disorder, they may also have a defect in absorption of vitamin B12, which is very essential for formation of hemoglobin. So some women are actually deficient in B12. So you can have all types of anemia in hypothyroidism, and it is a very common problem in uncorrected hypothyroidism.
Thank you very much, doctor, for answering that question. We'll move on to our next question. It says, why is there a weight gain during hypothyroidism? Who
Dr.
would like
Sai,
to answer?
Uh,
yeah, yeah, go
so,
on.
yeah,
Weight gain.
hypothyroidism, as we all already heard regarding that, it is going to affect the metabolism, and also it causes fluid retention. So these are the main reasons the cholesterol metabolism is affected, fat mobilization is affected, and these are the few things which are affected by lack of thyroid hormones, and also the fluid retention is there. All these things will result in a mild weight gain of 3 to 5 kgs or 3 to 6 kgs. That's all. So rest all weight
All,
gain is because of the dietary intake, not because of the
all.
hypothyroidism.
No, thank you so much, Dr. Chaitanya, for answering that question. We'll move on to our next question. It says, what is the chance of a patient having autoimmune polyarthropathy for more than 10 years getting thyroid disorder?
The answer,
Yeah, yeah, go ahead. Go
Please
ahead.
go ahead. Please go ahead.
I think the person has asked like a self-explanatory question. He has already mentioned it is autoimmune. I presume it may be rheumatoid arthritis or any such autoimmune condition where it is a very, and thyroid also being one of the belongs to the family of autoimmune conditions. Chances that such a patient will have a thyroid problem will be more than 50%.
Mm-hmm.
So 10 years if they have not had, that is they are in the exception actually. Very often almost 60-70% of these autoimmune condition people, thyroid is a very common associate of those conditions, so chances are quite high. They need to regularly monitor. That's
All right. Thank you very much, Dr. Sriram. We hope that answered the question of the person who asked this. We'll move on to our next question. This question is for Dr. Sheshadri. So it's been mentioned, Dr. Sheshadri stated that we can take an extra dose in the morning after missing the dose the day before. Will it cause thyrotoxicosis?
It will not, because thyroid hormone tablets, they have a very long half-life. Okay. So yeah, it's a very long acting drug. So you are permitted to take the extra dose the next day if you miss the dose. But don't take too many tablets. That can cause problems. If you miss one dose, take the extra dose the next day. Don't take 5 tablets. That's not the correct thing. You are just compensating for the missed dose. That's all you are allowed to.
All right. Thank you very much, Doctor. I think it was a very beautiful, short, and sweet way of answering that question. Thank you very much for that, sir. We'll move on to our next question. Is there any relation between PCOD and hypothyroidism? Hypothyroidism.
Dr. Sriram, would
Yeah.
you like to answer that?
This is a PCOD association is in severe hypothyroidism. In fact, we call in our endocrine teaching purpose, we should rule out severe hypothyroidism before diagnosing PCOS. So, what happens in all the hormonal internal derangements which happen in PCOS, like the mild male hormone excess in a female, that mild insulin resistance, these things happen in hypothyroidism also. So, the first thing we do is to screen for hypothyroidism, rule out and treat it if it is already there. Similarly, hyperprolactinemia, where prolactin levels are high, and one more hormone called cortisol. These conditions should be ruled out before we diagnose actually PCOS. So in our typical medical college teaching, we call PCOS is a diagnosis of exclusion after these three conditions are. So, but this applies to only severe hypothyroidism. The problem comes in today's situation where everybody is obese, and due to obesity itself, the TSH is marginally elevated. Upper limit of 5.5, they have a value of 7 or 8, and they also have other features related to obesity. This is insulin resistance and PCOS. That PCOS and hypothyroidism you should not mix up. That's the answer.
Yeah, just to add to that, that's
Yes,
why
sir.
I put up that picture of that very obese lady, right? Now, obesity itself, as Dr. Sriram very clearly mentioned, can cause a borderline increase in TSH values. That is because of insulin resistance that occurs in obesity. That should not be construed as hypothyroidism at all. Those patients only need to focus on weight reduction by appropriate lifestyle modification. And do not confuse that with primary hypothyroidism, where the TSH values are high. And as we mentioned, the weight gain is only a little bit. People gain about, say, 4 or 5 kgs over a month or so, developing hypothyroidism. Markedly obese people, marginally elevated TSH, most likely they don't have hypothyroidism. All right.
Thank you very much, doctors, for giving your insights on that question. We'll move on to our next question. This is a little lengthy one, so let's see who can give us the answer for this. So this woman says, I have TSH level 4.9. 5 years ago, my doctor said there is no need for medication, but my fatigue level increases day by day, but I ignored it by doing yoga. Now I have a TSH level 5.9 and I've developed a breast cyst. For that, I went to the doctor and I was advised to take Tyronorm 2.5 mg, and she also said that a fluid has developed in the loose muscles area if thyroid is untreated. So, is my breast cyst due to untreated thyroid? Who would like to answer the question? Can you please go ahead?
I think this breast lesion has nothing to do with the thyroid gland, okay, or hypothyroidism. You had a marginally elevated TSH value, and your doctor decided not to treat and only to follow up. And you say TSH level spontaneously came down from 11 to 5.9, which is a good thing. The breast lesion is unconnected and is unlikely to show any change with thyroxine therapy. So I don't think it is really required.
Thank you very much, doctor, for sharing your thoughts on that. Our next question is, will taking Tyronorm 100 mg regularly increase my cholesterol levels?
Uh, Actually, the relationship between thyroid hormone and cholesterol is interesting. When you have severe hypothyroidism, I mean, the kind we used to see when we were medical students when tests were not available. Severe hypothyroidism, patients used to have high cholesterol levels, and you treat severe hypothyroidism with thyroxine, cholesterol levels become normal, right? Now, what we are seeing nowadays is we pick up patients with hypothyroidism fairly early. When the TSH level is somewhere around 20, 25, we diagnose. And they also have an elevated cholesterol level. That is unlikely to improve with only thyroxine. Okay. So you give thyroxine, their thyroid functions will normalize, but the cholesterol levels will remain high unless they also follow lifestyle modifications. And even in spite of that, if that doesn't come down to normal, we may sometimes be forced to use, in addition, a statin to control the lipid level, depending upon whether there is a cardiovascular risk. Okay.
Oh,
So if you have hypothyroidism and you are on treatment and your thyroid values are under control, cholesterol is still elevated, then it is not due to hypothyroidism. The cholesterol elevation is not due to hypothyroidism. You require to address that separately.
all right. Thank you very much, Dr. Shadri. We hope that answered the question. We'll move on to our next question. It says, someone says, I'm taking my medicine regularly and taking food after 1 hour as prescribed by my doctor. Still, my TSH is high. What should I do?
How high? I
The
bet,
values.
I bet, I bet, I bet the TSH will be some 5, 6, 7, 8, that range. And I bet that the T3 and T4 values are normal. This is what I see day in and day out. Okay. And the question I ask my patients is not, are you taking your medicine regularly? I ask them, how many tablets did you miss in the last 1 month? Usually I get a more truthful answer than. They usually say, oh, I missed a couple of days. How many days in the month before you gave your blood test, how many days did you miss the tablet? Oh, I was traveling, so 1 or 2 days I missed the tablet. Okay, so this is what is probably happening to you. Okay, so if you are very regular with treatment and still the value is high, it calls for a slight increase in the dose of thyroid.
Thank you very much, doctor, for sharing your thoughts. We hope that did answer the question. Our next question is, can hypothyroidism lead to obstructive sleep disorder? Anyone who wishes to answer can go ahead.
Sai,
Yes, sir.
Sai.
Hypothyroidism is known to cause obstructive sleep apnea at various levels. One thing is there is a deposition of the growth of the pharyngeal tissues, which can cause obstruction. Another thing is it can cause a restrictive type of lung disease. And so, from the upper airway to lower airway, it is going to affect in various ways. There is also interstitial fluid deposition also in the lung, and there is a deposition of the growth of the tissues in the your neck, in the pharynx. So all these things result in a case of obstructive sleep apnea in these individuals. So it has been shown in many studies also. So hypothyroidism is clear-cut associated with obstructive sleep apnea.
Thank you very much, Dr. Chaitanya. I think that would have answered the question of the person who asked it. We'll take two more questions and then we will wrap up our webinar. So our next question is, will exercise reverse the thyroid disorder and can I stop taking pills?
Oh, that that will be a very simple treatment. I think we should learn from. The question is, theory, in a typical medical, you are stimulating my curiosity. If you lose weight, we just now said that TSH can get elevated due to significant weight gain. The reverse can happen if you do significant exercise and dietary restriction, lifestyle measures, and lose significant weight in a healthy way. Then TSH from the borderline elevation of 7, 8, etc., can come down to this 5. That way, some people can argue, yeah, I lost weight, I did yoga, and my TSH. Otherwise, this other pure pathological conditions which we discussed today, hypothyroidism of that severe variety, very unlikely to go by exercise. But please continue with your exercise because it is good for your cardiovascular and other benefits, not for thyroid.
But just an add-on to
Please,
that,
yeah.
please do your exercise. Very good. Stick to your diet. Excellent. But if you have been diagnosed or confirmed permanent hypothyroidism, do not stop your tablets. Okay.
Your doses may come down. That can come down if you lose some.
Yeah.
Thank you very much, sir. So we'll go on to our last question. So this question is having a thyroid disorder something I should be ashamed of? How should I be confident in this issue? So I will do this thing. We'll answer. All three doctors can take this question, maybe like 1 or 2 points each, and let's see how well this goes. We'll start with Dr. Chaitanya. You can go ahead. Then Dr. Sriram, and then Dr. Shashwat.
So thyroid disease is, as Sar said, the cause for hypothyroidism and hyperthyroidism is autoimmune. So which is unpredictable. So shall we be ashamed of it? Means it's not like that. So one thing is you don't know when you are going to develop the thyroid disease. Only thing is when you are symptomatic, get a testing done at the earlier date and start treatment at an earlier date. There is nothing to be ashamed of it. So only whenever in case of hypothyroidism, we are giving a natural hormone in the form of a tablet. It's not like any other medication. So there are least side effects when it is monitored and kept under control. No side effects are also noted with this kind of treatment.
Dr. Sriram, your insights on this question.
Oh, that is a very. I don't know why that person is really hurt by something. I think I rarely get that question. Anyway, as he already nicely pointed out by Dr. Chaitanya, there are, for that matter, any condition in today's advanced medical world. Even there was a time when HIV and other things, because of the way they contracted the infection, people used to bring social stigma into it. But it's so well controlled today, and people are living like anybody else, like diabetes or hypertension. So thyroid is a very, very simple condition. I don't know why it is brought into this level. I think somebody has misguided this person who has this question. It's a very easiest. In fact, even in thyroid cancer, which is not the topic for discussion today, one of our senior physicians used to say, if God tells you that you will have a cancer, then I will say I will have thyroid cancer because it is treatable, in fact, literally curable also. So we need not worry about thyroid problems. Diagnosis, treatment, everything is simple, provided you understand and just follow the simple rules of the this medical condition. And nothing to be ashamed or feel guilty or feel depressed about. It is a very, very straightforward condition to treat.
And
Thanks.
Dr. Shashatji, any closing remarks that you want to give on this question?
I understand why this person asked this question. I do have some patients who come and ask me this question. This is usually women who are not married, contemplating marriage, and their mother. And they are the ones who come and, they want to know whether this is something that should be divulged to the prospective group. Okay, that is where the issue comes, because everybody is under the impression thyroid problem can have effects on pregnancy, may be associated with infertility, etc., etc., etc. So the way I deal with this is to say that if you take your treatment regularly and keep your thyroid functions under control, there is no difference between you and another normal person. Okay, so it's not a condition
Right.
to be ashamed of, think that it has a stigma. But if you are going to get married, I think you need to actually discuss this with the other side and be frank. I don't feel that it is a good idea to keep it under the, you know,
Right.
this thing, keep it covered, and because later on it can lead to disharmony. So I always tell them to be frank, and if the other side they want to come and discuss the issue with me, I say fine, bring them along. I'll talk to them. Right?
Oh,
Yeah.
Hi,
I
Hiba.
think that, yes,
There
something
is
someone
one,
was.
one question from one of the persons. I think that this answer might help him.
Sure,
He's
sir,
saying
you
that
can please go.
my wife is having multinodular goiter of 5 centimeter size. We have underwent FNAC test. It is Bethesda 5, and her T3, T4, and TSH are normal. The doctor advised to remove thyroid gland. What are all the problems for patients after removal of thyroid gland? Any treatment without removal of glands? This was his question.
Yes.
Over to you, sir.
Who would like to answer the question can take it.
If you are saying Bethesda 5, which basically means that the pathologist suspects that you may be having a thyroid cancer, right? And that is the reason they have advised removal of the thyroid gland. And I think that would be the appropriate thing to do, correct treatment, because thyroid cancer, as Dr. Sriram said, is a curable cancer in most instances. So you need to take treatment early, do not delay it. And after treatment, there will be follow-up. Sincerely follow all the advice that is given to you in terms of follow-up. And I think you should do well. But if you say I'm not going to have treatment now, I think it is it's not the correct thing that you are doing to yourself. Okay.
Thank you very much, sir. And also to those who have put up their queries, most of your queries will be answered via email. So we're very sorry we couldn't take up everything. We had like 66 questions and a few minutes to answer them. So all those queries which haven't been answered, you will get your answer via email. So that's about it. So with that being said, I think it was a great 1 hour
Thank
session that we had from all the three doctors who shared their insights with us today. So firstly, thank you so much for your time, doctors. It was lovely hosting all of you today. This is the webinar on managing and understanding thyroid disorders brought to you by Naruvi Hospitals, Belur under the wellness series of The Hindu. Thank you for the audience who asked questions. Thank you for those who came and participated in this webinar. Remember, do take care of your health because indeed it's the need of the hour. And like I mentioned in the beginning, health is wealth. So thank you all for joining in and I hope you all have a great Sunday ahead. Thank you very much,
Thank,
doctors, and thank you very much, participants, for participating.
thank you.
thank you, sir.
Thank you.
Thank you.
Thank
Thank you all.
Thank you,
Thank you
Sriram,
very
sir.
much.
Thank you, Hib.
And thanks to the people the audience who participated. That was nice.
Yes.
Thank you very much. And everybody, do take very good care of yourselves. Looking forward to seeing you all soon. Thank you.
Thank you.
Thank you.